So thank you. I would be talking to you about types of riboflavin and current status of accelerated cross-linking. Now, if you look at keratoconic cornea, important thing is that it does have reduced biomechanical stability, and when cross-linking is done, there is alteration in the pattern of the collagen. And corneal cross-linking does allow corneal stiffening by forming crosslinks, and I'm sure this has already been covered in the previous talks with 330% increase in the biomechanical resistance. Now, if you look at the basic structure of riboflavin, it is a photoactivated chromophore with absorption peak at 370 nanometers, large hydrophilic molecule, inadequate to penetrate through the intact corneal epithelium, and that's why it requires corneal deepithelization so that the penetration increases. Uh, there are basically, if we look at the US FDA approved solutions, two of them. One is riboflavin 5 phosphate with dextran, and the other is riboflavin 5 phosphate 0.1%, or what we say as hypoosmolar, which is used for hypoosmolar collagen cross linking. Now, if you look at the various riboflavins here, of course, this is a busy slide, but you have 0.1% riboflavin with dextran, then you have 0.1% riboflavin without dextran, then you have 0.25% riboflavin for transepithelial collagen cross-linking because the epithelium is not debrided, so the concentration is higher. Then riboflavin with HPMC because dextran causes thinning, and then same is used for other procedures when intrastromal applications are done. So dextran has osmotic effect, and that reduces the corneal thickness, and the HPMC base that way is better because it increases the diffusion rate and reduces the loading time. If you look at dextran versus HPMC based solutions, as far as the clinical outcomes are concerned, it is known that the one with the dextran have greater percentage of penetration, and so this is responsible for transient thinning. This is just to show the same from Peshke without any financial interest. So isosmolar riboflavin is the one which is most commonly used with 20% dextran. Hypoosmolar, on the other hand, is 0.1% solution, and it is dextran free. Now, there are standard formulations which do not penetrate well. So, in order to increase the penetration, you can use various agents like benzalkonium chloride, EDTA, vitamin E, TPGs, or iontophoresis can be done. People have used even oral riboflavin, but it has systemic side effects, so it is not currently in use. As far as the Dresden versus accelerated protocols are concerned, the classical Dresden protocol was when you used the UV radiation 3 milliwatt per centimeter square for 30 minutes. And accelerated protocol is eventually could be any one of the following. That means 6 milliwatt for 15 minutes, 9 milliwatt for 10 minutes, 15 milliwatts for 6 minutes, or 30 milliwatt for 3 minutes. Now, more than this, people have even done 40 milliwatts, but that they have not found it. 45 milliwatts, they have not found it to be efficacious. Now, this is as per the Bunsen-Roscoe law of reciprocity, where the total energy has to be 5.4 joules per centimeter square. There is a need for rapid protocols because for patient compliance, and also for the fact that if you have prolonged UV radiation, then there's prolonged dehydration, and that can lead to corneal thinning. So this is one study which looked at standard versus accelerated cross-linking, and in terms of efficacy and flattening, there was not too much of a difference, but demarcation line was more superficial in accelerated collagen cross-linking than in standard cross-linking. And this was a meta-analysis of 1,000 plus eyes, which favored accelerated cross-linking, except for the fact that the deeper demarcation line is present with the collagen cross-linking. This is again epi of standard versus accelerated cross-linking, which shows that there is no difference in the depth of the corneal stromal demarcation line between the two. Now, in pediatric eyes, also accelerated collagen cross-linking have been evaluated and are found to give good results. And here, Vibextra is used. That means the concentration of the riboflavin is increased because some people like to do transepithelial collagen cross-linking, especially in pediatric eyes. Now, accelerated collagen cross-linking can be pulsed or continuous, normal fluence or high fluence, pachymetry-based, photorefractive interstromal cross-linking, or LASIK extra can be done. So basically, the high fluence accelerated cross-linking causes significant epithelial remodeling, and there are hardly any changes in the thinnest pre-op areas, and it reduces the thickness variability from central 6 millimeters. And if you look at the epithelial modeling, then there's significant epithelial modeling, which is observed at 6 months, and this does improve the regularity. Now, this is a study which compared pulsed versus continuous accelerated collagen cross-linking, and pulse light allows optimized intraoperative oxygen availability, improving the post-op functional outcomes. And this is just to show the confocal picture of the same. And notice that with the pulse light, the demarcation line is clearer as opposed to with a continuous light. And with the pulse light, the apoptosis is also deeper and the demarcation line is also deeper. Now, this is the pachymetry based accelerated collagen cross-linking based on the M nomogram, which allows selection of the treatment protocol to achieve the desired cross-linking depth. And people have even done customized cross-linking, which is found to be safe and effective treatment for low grade of myopia. LASIK extra is, of course, when you combine LASIK with accelerated collagen cross-linking, and it is better both for refractive and keratometry stability, but there are no long-term results or randomized studies to prove the same. So these are the various studies of accelerated collagen cross-linking with good results. Flattening does occur, and pachymetry does reduce, at least in the initial post-op period. And there are several concerns, however. The concerns are the biomechanics, and because of the increased speed of the procedure, there is reduced time for oxygen diffusion, and this may create a hypoxic environment. And so, biomechanical effect of collagen cross-linking is oxygen dependent, and that is something which we need to know. Dr. Rajesh has done a wonderful study on the oxygen role of oxygen in collagen cross-linking, both in normal corneas and in thin corneas, and I'm sure he must have told you about the results. Now, there are limitations in the current literature because the progression criteria is a little different in various studies. Grading method severity is different. Riboflavin solution times are different. Concentrations are different, and the soaking time is also different. Also, the follow-up duration is not same for all studies. So, to conclude, accelerated collagen cross-linking is safe and allows corneal stiffening in cases of progressive keratoconus. There are variable results reported in different studies in terms of functional outcome, and it does show promising results, at least the short and the midterm, but long-term studies are required. So, recommendation is multicentric trials and the long-term studies, especially in high-risk group like children and syndromic associations. Thank you very much for your kind attention.
Thank you, ma'am. Any question or any point that?
Yeah, I have a question, ma'am. This regarding in children. So, have you found that you would need to add on another procedure for children? And if so, how long does the initial procedure last?
So we have done a study which has been published in American Journal of Ophthalmology in 116 patients with keratoconus, and we found that we had to repeat collagen cross-linking in 8% of the children. So the study that is published in is 1 year now. These children have followed up close to 10 years now, and we do have to repeat, especially in case of children, and more so if they have vernal keratoconjunctivitis. So, repeat collagen cross-linking is a reality.
And at what time from the initial procedure?
So, if whenever, of course, you closely monitor them, and whenever you think that it has progressed, then you need to repeat it. Having said this, suppose initially they've undergone an accelerated collagen cross-linking, which was our protocol for children. We then, in a repeat procedure, try to do a conventional cross-linking.
And what's the youngest that you have done?
So the youngest we've done is 7-year-old.